Dr. Matthew Matasar. I'm a member of the lymphoma and the adult BMT services at Memorial Sloan Kettering Cancer Center. I do research in relapsed aggressive lymphoma with new drug development, as well as studying the late effects of cancer therapy on survivors. The biggest challenges in the management of lymphoma are taking care of patients with lymphoma. There's problems from start to finish, from trying to make an accurate diagnosis, to determining optimal first-line therapy, survivorship care, management of relapse disease. At every stage in the journey of a patient with lymphoma, we still face challenges, and we know that we need to do better. Antibody drug conjugates, which essentially are an antibody, a protein that is a delivery mechanism with toxins that are conjugated to that antibody. This complex is internalized inside of ideally a cancer cell, and the toxins released internally as a way to deliver a highly potent therapy intracellularly, minimizing off-target effects. These antibody drug conjugates, or ADCs, have been developed in a wide variety of malignancies. Brentuximab vedotin is the first that we've had approved in the treatment of hematologic malignancy, namely Hodgkin lymphoma, as well as a form of T-cell lymphoma called anaplastic large cell lymphoma. These are very potentially effective treatments, maximizing delivery of potent therapy with minimizing toxicity. We're developing a number of these in non-Hodgkin lymphoma as well, particularly for B-cell malignancies. Polatuzumab vedotin, or PV, is one that is further along its developmental pathway, and we reported results here at ASH demonstrating marked activity of polatuzumab vedotin in combination with bendamustine and rituximab in the treatment of relapsed aggressive non-Hodgkin lymphoma in patients who don't have other curative options. This is going to be an important therapeutic opportunity and modality moving forward across the range of lymphomas. So when we look at relapsed and refractory non-Hodgkin lymphoma, there's a wide variety of drugs that are in active development, but they seem to fall into a certain number of categories. The first is antibody drug conjugates, which we just discussed with polatuzumab vedotin and others like it, that are being used either as monotherapy or in combination with chemotherapeutic agents. The second is the world of immuno-oncology, and there's a number of immuno-oncologic approaches to relapsed and refractory lymphoma, including chimeric antigen receptor modified T cells, or CAR T cells, as well as other antibodies that may have the ability to replicate the effectiveness of CAR T cells without the therapeutic challenges of administering a living drug, such as the biphenotypic antibodies that are T cell engaging. The last area would be small molecule inhibitors, trying to leverage our increasing understanding of the complex biology of relapsed lymphoma and trying to understand what of those changes biologically in these cells may be druggable. There's been a lot of progress here reported at ASH, some of which has the potential to be truly practice-changing. The first, which we're going to be hearing at the late-breaking abstracts tomorrow, is the Murano data, looking at the use of venetoclax in CLL, which is a form of lymphoma, showing that venetoclax in combination with rituximab seems to be much more effective than a more traditional program of bendamustine and rituximab. The second is the Echelon-1 trial data that were reported yesterday at our plenary session, showing that the combination of brentuximab vedotin with the AVD chemotherapy triplet seems to be more effective than the ABVD standard of care, with an improvement, small but measurable, in progression-free survival, with a treatment that is potentially less toxic, particularly for patients in whom bleomycin may pose health risks.